Good morning. Welcome, everyone. In 2 minutes, we will start, and it's a 3 minutes presentation, so it's very important that we respect the time. And after 3 minutes, we will have to ask you to stop. Please think about that. And we will welcome now the first presenter, Dr. Ota from Japan.
Good morning. I'm Soichi Ota from Kyoto, Japan. My presentation today is about the association between the radius and the lunate on lateral view X-ray of the wrist. A line extending along the border aspect of the radial shaft is considered to roughly bisect the radial articular surface and the lunate. However, detailed measurements have not been reported. We defined the measurement procedure and investigated the association between the lunate and the radius. We measured 155 lateral wrist radiographs. Mean age was 55 years old, 53 male and 98 female. Right side is 71 and left side is 80. Fractures, tumors, OA and RA were excluded. Definition of lateral wrist radiographs is the palmar cortex of the pisiform should lie between the anterior surface of the distal pole of the scaphoid and the anterior surface of the capitate, like this. Measurement procedure is as follows. First, 3 points on the proximal articular surface of the lunate were randomly selected, and the center of a circle passing through the 3 points was found as a lunate rotation center. And a line parallel to the axis of the distal radius was drawn along the border aspect of the distal third of the radial shaft. And the distance between the lunate rotation center and the extended line along the border aspect of the radial shaft was measured. Results. Most of the lunate rotation center was located on the center of the distal articular surface of the lunate. The distance between the lunate rotation center and the line extending along the border aspect of the radial shaft was between minus 2.34 and 3.97 millimeters. Mean value was 0.09 millimeters. We expect this measurement to be useful in the treatment of severe Smith fractures or fracture malunions. But because of individual variation, the measurement in the unaffected side would be better to use as a basic reference value. Thank you.
Thank you for your presentation. Just a question and a short answer, please. What is actually the aim of your measurement?
The purpose is for the correction of septomy for first. I study this for correction of septomy for volar displaced malunion, fracture malunion. Which portion should be the lunate lie? Which portion is best position is very difficult in some cases, especially in intra-articular fracture malunion. And so I think this is one of the index.
Thank you very much. We go to the next presentation with Dr. Wilcke from Poland.
Hello, ladies and gentlemen, chairpersons. My name is Zbigniew Schlosser, and on behalf of Professor Wilcke, I'm going to present you the results of comparison between QI fixation, and palmar locking plate for treating distal radius fractures. We have nothing to disclose. You know that the distal radius fracture is one of the most common problems in hand surgery and wrist surgery. We need to treat more than 100,000 patients in Poland each year, and the cost effectiveness of treatment is an issue in this situation. The most modern techniques are prefer plate fixation, but in some centers we do use QI pinning. We treat about 400 patients each year. Most of them are treated operatively. We try to keep the QI fixation for simple fractures, and if we have more complex articular fractures, we go for plate fixation. We analyzed about 460 patients with these radius fractures. We follow up them after 3 and 12 months. We analyze range of motion, grip strength, dash scores, and of course radiological issues. Augment QI fixation. The most important part is to reduce the fracture properly. If we didn't obtain proper close reduction, we change into open operation. The important thing is here that you can see a Kapanji intrafocal pinning, which supports the base of the fracture, and then additional 2 to 3 key wires going from radial styloid, and 1 additional key wire from ulnar side. And it was supported with a slab for 2 to 4 weeks, depending on the situation. We asked the patient to mobilize the fingers, elbows, and arms. Plate fixation was done with the standard AO technique with different brands of plates. As you can see, this is the demographics. 3 months, we have better results with plates for strength, so early better strength, and better dash scope, but without really differences in range of motion. After 12 months, we can see that we have quite similar functional results, being better dorsal extension for the palm plates. If we compare radiological results, of course, plates are better. If we compare articular fractures, complex articular fractures, there is no doubt that plate fixation we have better results with plate fixation. We have like 2 to 3% complications rate with QI. It's not 50%, as somebody stated yesterday. And conclusion is that being guided by this algorithm, it's a reasonable choice of treatment of distal radius fractures, a balance between clinical and cost effectiveness. And on behalf of organizers, we would like to invite you to Polish Hand Surgery Society meeting, which will run in September this year. Thank you.
Thank you very much for this presentation, a comment. It's a good idea to remind of the interest to use the K-wire stabilization, and this procedure stay a good indication in a chosen case. In your study, you use a specific algorithm to separate the group. It's not a BA in your study?
Could you please repeat the last question? I didn't understand the question. The last part.
For your methodology of the study, you separate 2 groups in the specific AO classification.
No, it really depends on the complexity of the fracture. It's not that it was a 0-1 method. Sometimes we use, for easier fractures, we use key wires, and for more complex, we use plates. But generally speaking, we reserve key wires for, so we could compare sometimes same subtypes of AO fracture types. So that's why we could analyze C2 fractures, for instance. But it's not 0-1 method.
Okay.
Okay.
Thank you.
Thank you.
Thank you very much. Now we welcome Dr. Kahuyun.
Yes, Kaihan. Good morning, everyone. My name is Kaihan Kim, and I will be presenting vitamin D receptor expression in skeletal muscle of women with distal radius fracture. Vitamin D is known to be related with muscle frailty, and it exerts its activity by binding to vitamin D receptor. And patients with distal radius fractures are known to have lower level of serum vitamin D levels and higher prevalence of sarcopenia. So the aim of this study was to measure VDR expression in skeletal muscle formed in women with distal radius fracture using immunohistochemical analysis, and to evaluate the relationship between VDR expression and sarcopenia. Patients older than 50 years of age with distal radius fracture were included in the study, and patients' functional status evaluation, including grip strength measurement and gait speed, were performed, and body composition analysis was done to measure appendicular limb mass. And for muscle histology characteristics, we measured cross-sectional area of each muscle single fibers. For the immunohistochemical analysis, we defined staining index, which is the multiplication of staining intensity and the percentage of positive cells. As you can see here, it's too bright to see. The dark ones are the cells that are stained, and the blue ones are the cells that are not stained. For the results, total of 45 patients were included in the study, and 12 patients showed a decreased lean mass. And out of 45 patients, only 2 patients were diagnosed with sarcopenia, which is defined as low lean mass index and decreased grip strength. And correlation between the clinical parameters, you can see here, it's vitamin D receptor index is negatively correlated with BMI and appendicular lean mass index. And we divided the patient group into 2 groups according to appendicular limb mass index with a cutoff value of 5.4, which was suggested by the Asian Working Group for Sarcopenia for diagnosis of sarcopenia. And patients with lower appendicular limb mass index showed a significant higher VDR index and a smaller cross-sectional area of muscle fibers. For the conclusion, in patients with distal radius fracture, group with lower appendicular limb mass showed significant higher VDR expression and lower muscle cross-sectional area in the forearm muscle cells. And our hypothesis is that VDR expression may be upregulated to compensate for the decreasing muscle mass. And further studies are necessary to explore the exact role of VDR in skeletal muscles. Thank you for your attention.
So, thank you for your presentation. In one sentence, what is your clinical relevance for this study?
We wanted to make sure if patients with distal radius fractures show lower serum vitamin D levels, so we wanted to make sure if it's appropriate to prescribing vitamin D to the patient makes sense. We wanted to make sure the mechanism, how it works. So we wanted to make sure if it's better to take the vitamin D medicines.
Thank you very much. Dr. Ribeiro from Portugal. Next presentation, please.
Good morning to everyone. We have no disclosures. Ulnar styloid fracture, as we all know, is frequently associated with distal radius fractures. Nonetheless, its clinical impact and its treatment are still very debated. So the objective of this study was to evaluate the outcomes of patients submitted to volar plate fixation of the distal radius fracture and screw fixation of the ulnar styloid when there is DRUJ instability, with or without wrist arthroscopy, depending on the type of distal radius fracture. So we performed a retrospective study where we searched all the information in the electronic database. We excluded the patients with additional fractures, with cognitive impairments, and with previous history of traumatic or degenerative hand and wrist injuries. And we ended up with 26 patients, which met the criteria, with an average age of 51.2 years old. We studied all these variables, the type of distal radius fracture according to the AO classification, the presence of associated injuries, and then the DASH scale, the PRWE. We used the visual analog scale to measure pain at rest with exertion and the satisfaction with the procedure, range of motion, complications, and the need for reoperation. These were the results that we got: 12 extra-articular fractures, 14 intra-articular, 9 type B and 5 type C. 5 of the 26 patients had associated injuries, specifically TFCC and scapholunate ligament injuries. The average total DASH was 16.5, the PRWE was 18.4. Regarding the pain at rest, patients rated it as 1.46 on average, 2.08 with exertion, and the satisfaction rate from 1 to 10 was 9.12. Regarding the range of motion, flexion 66.4 degrees, extension 64.6, pronation 91.8, and supination 98.6. So quite nice results regarding these range of motions. We had 2 complications, a carpal tunnel syndrome and a screw loosening, and 1 patient had to be reoperated for the carpal tunnel release. So we think that this treatment produces good clinical results, allows a good recovery of wrist mobility with what it seems little complaints of pain and few complications. Nonetheless, we still believe we need some more studies regarding this, comparing with a control group with more patients so that we have a substantially result. Thank you for your attention.
A little comment. It's necessary for me to study comparative work between without and with stabilization. Question. Do you think that it's necessary to stabilize the styloid for all cases of distal radius fracture?
Well, the patients where we performed this procedure had all the RUJ instability. So we checked them preoperatively, and then with the wrist arthroscopy, after we fixate the distal radius, we checked it again. So in those cases, we always did this procedure. But it would be interesting to compare like 2 groups when we would fixate like a prospective randomized study, so we could get more accurate results.
Okay, thank you very much.
Next presenter is Dr. Landgren from Sweden.
Thank you. Good morning. So I would like to present a study between fragment-specific versus volar locking plates in distal radial fractures. This is a study that's we previously presented the 1-year data, and is published in the Journal of Hand Surgery in 2017. So we now have long-term data. So the aim of this study was to evaluate the wrist function, evaluate the complications in secondary surgery after a distal radial fracture treated with either volar locking plate or fragment-specific fixation. Our 1-year data showed no difference in grip strength, range of motion, or other secondary outcomes. We did, though, see a difference in complications. We had more overall complications in the fragment-specific group compared to the volar locking plate. And there is been publications out that many volar locking plates need to be taken out over time, and therefore we'd like to analyze if this was the case in our group. So the design was the prospective randomized trial with 50 patients. Inclusion was 18 to 70 years, and AO type A and C fractures. The dorsal angulation, more than 20 degrees, more than 2 millimeters of axial compression on our variance, or incongruous in the RC or the DRU joint. So the results. We found no difference in our primary outcome, which was grip strength, measured as percentage of the contralateral size, so 92% in the fragment-specific group compared to 98% in the volar locking plate. Nor a difference in the range of motion or median quick dash, which was low in both groups, of 3 versus 5 in the volar locking plate. We did see complications. One patient in the volar locking plate group had a de Quervain syndrome, which was treated surgically. We had a couple of patients with nerve issues, carpal tunnel syndrome, and radial neuropraxia after 7 years follow-up. One patient had an EPL rupture and was treated with ERP EPL transfer. Regarding secondary surgery, we had 4 patients in the fragment-specific group treated for repeat surgery, extracting the osteothesis material, versus 5 patients in the volar locking plate group. So at 7 years, we didn't find any difference in the radiological outcome either. To the left, you see the fracture at 1 year, and to the right, fracture at 7 years, and versus on the volar locking plate, you see the same. So, well, in conclusions, no difference in grip strength, range of motion, quick dash, nor in rate of secondary interventions between the two implants. Thank you.
Thank you. I don't think we have time for any questions,
okay.
So we welcome the next presenter, Dr. Wilcke.
Thank you. Good morning. My name is Stephanie, and originally I'm from Germany. Right now I'm a fellow in Brisbane, Australia. I'd like to present our results regarding the question, do postoperative radiographs change the management following internal fixation of distal radius fractures? That was our main question. Our secondary one was, are there guidelines for where X-ray may be appropriate? So we did a single-site retrospective study of a period of 5 years. Our exclusions were shaft fractures and malunions, as well as planned return to theater, such as X-fix to plate, and of course, if we lost the X-rays. We found 543 operatively managed fractures, and 3/4 were complex and intra-articular. 84% were fixed with a volar plate. So what we found is that of all those patients, only 7 returned to theater based on those postoperative X-rays. And the main point and the key point to stress here is that in all 7 cases, the reason for return to theater was already visible on intraoperative imaging, and there was no other change in postoperative management. So there are significant financial implications, of course, of doing all of those X-rays, and the potential savings in not doing those X-rays would be immense. Our evidence does absolutely not support routine postoperative imaging, and there are benefits of minimizing X-ray requirements. Our numbers are inadequate to formulate clear guidelines. However, we would propose those guidelines. We would say ensure that you have adequate intraoperative fluoroscopy. Look at these images very carefully and save multiple planes, not just 2 maybe. Early X-ray is advised if you have an early injury, a new fall or anything, change in symptoms of your patients, you're concerned regarding the adequacy of your fixation, or you choose alternative fixations such as K-wires, non-locking fixation, and late X-ray may be advised if you have a clinical indication for it, for example, plate removal, such as pain or crepitus. Thank you very much.
Thank you for your presentation. How often do you go for CT scan postoperatively?
I'm sorry?
Actually, how often do you go for CT scan postoperatively? Actually,
almost never, to be honest.
To be honest,
if we're concerned about non-union.
Okay.
But I have to say that we have a very low threshold of bone grafting, so we have a high fusion rate, I would say.
Okay, thank you very much.
Thank you.
Next presentation from Argentina, Dr. Pablo De Cali, please.
Good morning. I have no disclosures. Our objective is to evaluate the repercussion on the hand of distal radius fracture non-union and analyze a functional improvement after the radius was surgically stabilized. We retrospectively found 15 patients with distal radius non-union, mostly referred to our institution for hand dysfunction. We included those patients who had complete PROMs for pain and hand functional subjective evaluation, surgically stabilized with different ways, and at least with 3 years follow-up. This included 10 patients. We focus on pain and function evaluation. Initially, 6 of the 10 patients had CRPS, 7 couldn't touch the palm of their hand with the tip of the fingers because of a limited range of motion. Pain at rest averaged 7.2. 9 of the 10 patients had pain with moderate activity, so permanent pain, and 9 had DASH score worse than 45 with an average of 63. With 3 years follow-up after operation, all could make a full grip. Pain at rest improved to 0.3. We have no CRPS. Half of the patients have pain, but only with heavy efforts, and 5 patients had no pain at all. And all patients had a DASH score less than 20, with a total average of 11. Finger motion, pain, and DASH score were significantly improved. CRPS was significantly improved after distal radius non-union and was very frequent, but it was resolved only after stabilizing the distal radius. Thank you very much.
Thank you very much for your presentation. It's a series with a height, average age. The result encourages us to stabilize the radius for patients even when there are this very old. Little question, what is your device when you perform scapulinate, radioscapulinate arthrodesis in this series?
Well, it's a large time. We had a lot of devices. There were different plates, more
a specific
of them,
plate,
most of them.
yes.
Sorry?
It's a specific plate, radioscapulinate arthrodesis.
No, not specific plate for arthrodesis.
Okay.
Just or dorsal plates, pipe plates adapted, or reconstruction of the radius itself without fusion.
Okay, thank you.
Or in cases of total fusion, the total fusion plate. Yeah.
Thank you. Thank you very much. The next is Keiichi Uematsu from Japan.
Good morning. My name is Professor Uematsu from Japan. Today TCP with unidirectional power structure. It's so-called UDP TCP, made by the Kurari in Japan, named Affinos. It's available in clinic from the 2050. So you can see the blood coming up, immediately coming up to the top through these unique structures. So this is the first clinical study for the displaced non-unstable fracture of the distal radius fracture in the elderly population treated with a UDP TCP. UDP TCP was placed in the gap interoperatively of the bony defects, and I usually use the 7mm cubic type. This study, I mainly focus on the remodeling of the UDP TCP and the clinical outcome. We had 36 patients more than 68 years old. The average is 74, and I used the poly-action locking plate the 70 and the monoaction the 90, and the affected limb was not stabilized postoperatively. We had no serious complication on the new beta TCP, and UDP TCP was significantly resolved at 2 months. That is interesting point, both at from the center and the peripheral of the materials. So I think the UDP TCP is a safe and convenient materials for the treatment of distal radius fractures, especially in the elder population, and it replaced within the suitable time after the grafting into the fracture sites. Functional assessment like ROM and the grip strength, the dash score was very excellent in the both group, but we saw the correction loss at the polyactional locking plate group. So I think that this material is beneficial for the distal radius fracture, but still the key factor, the most important point is the stable fixation. Thank you very much.
Can I ask you this bone substitute, is it soft or is it stiff or hard?
Oh, what?
The bone substitute?
Yeah.
Is it soft or
no,
is it stiff?
it's hard.
It's hard.
Yeah.
So do you think it would be possible to maybe fixate the fracture with a less invasive surgery for like with the...
Sorry, I can't hear that.
It's difficult up here. Do you think you could fixate the fracture with a less invasive method, such as percutaneous pinning?
No, I always use the molar locking plate.
Okay.
And the majority of the patients are C2 or C3.
Thank you. The next presenter is also from Japan, I think. Dr. Moritomo.
Good morning. My name is Akira Kawabata. Exact fixation of intra-articular fragment is essential during molar locking plate fixation of intra-articular distal radius fractures. We use intraoperative CT navigation to accurately insert screw in the intra-articular dorsal fragments. This study evaluated the accuracy of the procedure based on CT findings. As shown here, mobile CT gantry and the navigation system were used. Briefly, infrared captures the position relationship of differential array and pointer or drill guide. The display on the navigation screen indicates the position or direction of pointer or drill guide. We could predict distal screw insertion based on this display. This study analyzed the data from 18 intra-articular distal radius fracture treated with molar locking plate and intraoperative CT navigation. According to our classification, 3 cases were classified as C1, 7 as C2, 8 as C3. We assessed the gap and step off, and as well as calculated the mean minimum distance between the screw and the articular surface, and that between the tip of the screw and the dorsal cortex. We evaluated the 3 distal ulnar screw positions that affected the stability of ulnar dorsal fragment, and clinically assessed the mean risk score and dash score. The results showed that the reduction and stability of the articular fragment were good. The mean minimum distance between the screw and the articular surface were less than 2 mm both intraoperatively and after bone union. Fluctuation was minimum. The mean minimum distance between the tip of the screw and the dorsal cortex were less than 1 mm both intraoperatively and after bone union. Fluctuation was minimum. Distal locking screw were appropriately inserted as a subcondylar position and had sufficient legs to stabilize the dorsal fragment. There were no cases of inappropriate screw insertion, such as penetration into joint or positioning away from the dorsal cortex. Clinical result remains as a final follow-up. CT evaluation revealed that the screw had been precisely inserted as an articular fragment and bone union with good alignment had been achieved. The findings demonstrate the accuracy and the good clinical outcome of this procedure. Thank you for your attention.
Thank you for your presentation. Do you go for the navigation after reduction intraoperatively, or you do navigation before? And the next question, very short, how long does it take to you, the navigation extra to the time of the surgery you need?
I can catch.
Once again, you do navigation before you start with your reduction intraoperatively or after? First question. The next question, how long do you need as time for the navigation extra to your surgery time?
Operative time about 2.5 hours. It extended to 1 hour compared to conventional fluoroscopic procedure.
Okay, thank you very much. We go for the next presentation. still from Japan, from Dr. Matsura, please.
It is a great honor to be able to speak to you. Today I would like to talk about mechanism of Smith fracture. You know, in chorus fracture, distal fragment is dorsally displaced, whereas Smith fracture, this fragment is broadly displaced. We orthopedic surgeons had learned chorus fracture occurred when the hand is loading during dorsal flexion, whereas Smith fracture occurred during volar flexion. Indeed, in our survey, only 15% of patients were injured as a result of falling on the dorsal of the hand. On the other hand, 62% of patients were injured as a result of falling on the palm of the hand. However, we don't know the mechanism of such a fracture. The aim of this study was to clarify the pathogenesis of Smith fracture. First, finite element model were created to predict the type of distal largest fracture from CT data. Now, I would like to show you the movie about various types of fracture model, such as chorus fracture, Smith fracture, radial side fracture, chauffeur fracture, and scaphoid fracture. This is the result of a 36-year-old man. As the angle was decreased, the fracture line shifted to the volar side. In addition, Smith fracture occurred when the angle was 30 and 45 degrees. Smith fracture occurred when the angle between the long axis of the forearm and the ground was small. This same tendency was observed for 60-year-old man and 89-year-old female. So Smith fracture may occur as a result of falling on the palm of the hand with the wrist slightly extended position. Next, we examined to obtain experimental proof of Smith fracture using 10 fresh frozen cadavers. To simulate falling while the standing position, the palmar aspect of the carpus was fixed with the angle was extended at 30 degrees. Wrist fracture occurred by dropping of the weight. The type of fracture was evaluated by CT scan and dissection. As you can see, this is the arm of 94-year-old female. Smith fracture occurred along with ulnar neck fracture. We include CT scan of each specimen. Distal largest fracture occurred in 7 of 10 lists, and all of them are Smith fracture. Conclusion. Smith fracture occurs not only as a result of falling on the dorsal of the hand during volar flexion, but also as a result of falling on the palm of the hand during dorsal flexion. Thank you.
Thank you. Thank you very much for your contribution to the understanding of the etiopathogenic mechanism of Grauer-Schmidt fracture. But what is your clinical relevance with this result?
I think the textbook is long, so I hope the textbook change future. This is my opinion. That's all.
Thank you. Do you use the arthroscopic assistance for this Grauer-Schmidt fracture? When
arthroscopic?
Do you arthroscopic procedure to see the articular fracture?
No, I don't use it. Okay. I just directed the.
Okay. Thank you very much.
Thank you.
The next speaker is Lucas Horling from Austria. Thank you.
Thank you. So I'm here to talk about complications following ORIF of distal radius fracture with a palmar locking plate and our ways and strategies to deal with that. So the background of this short talk is a study we conducted in our department where we evaluated 114 patients with unstable distal radius fractures who were treated surgically, and we found a total complication rate of 27%, which appears to be high. However, that's mostly due to the fact that we included tenosynovitis, as we consider tenosynovitis a major risk factor in the progressive damage of tendons. The surgical revision needed was in 5% of the cases. So, in order to protect the tendons, the flexor tendons, it's utterly important to respect the watershed line. As when this is not possible, for example, due to the fracture configuration, and we end up with a zone grade 1 or zone grade 2 configuration, we strive for early blade removal within 3 months. In this short video here, we can see how a distally placed blade can irritate the flexor tendon. Here we see how we try to cover the distally placed blade with a pronator quadratus muscle in order to protect the flexor tendon until bone healing. So, in order to protect the extensor tendons, we routinely downsize the measured screw length by 2 mm. Furthermore, we perform a dorsal horizon view. This is necessary because, as you can see on the left side here in this small example, the dorsal cortex of the radius can be veiled by the listed tubercle in the lateral view, whereas the axial images in this case shows the truth, that is that the screws are too long and they reach the tendon compartment. So, furthermore, I want to quickly talk about the lunate facet fragment, as this plays an important key role in the treatment of DRFs and is often overlooked. It's an attachment point for the short radiolunate and the palmar distal radioulnar ligament, and the inability to fixate it properly can lead to an incongruity of the articular surface, an unstable DIU joint, and a carpal subluxation, as we can see here in the right picture. So it's difficult to address, especially in small fragments, so additional fragment-specific fixation may be needed. Thank you.
Yes. Thank you very much.
Thank you.
The next presenter is Dr. Ribeiro from Portugal.
We have no disclosures. So the aim of our study was to compare the type of injuries and outcomes between patients who suffer distal radius fractures and needed surgical treatments that suffer those injuries in a work-related setting versus a non-occupational setting. So we searched through our patient database. We excluded patients who were younger than 18 and older than 65 years old, patients with additional hand and wrist fractures, cognitive impairment, and with previous history of traumatic or degenerative hand and wrist injuries. So we ended up with 51 patients in total, 32 with non-work related injuries and 19 with occupational injuries. For a more homogeneous group comparison, we randomly removed 13 patients from the non-work group. So we ended up with 2 groups of 19 patients. The occupational injury group with an average age of 44 years old and with male predominancy, and the non-occupational injury group with an average age of 51 years old and with a female predominancy. All patients were treated with internal fixation with a volar locking plate with or without wrist arthroscopy, depending on the type of the distal radius fracture being extra or intra-articular. So all patients were evaluated 12 months post-operatively. And with a DASH scale, PRWE, we used the visual analog scale to evaluate pain at rest with exertion and the level of satisfaction with the procedure, range of motion, the type of fracture, the existence of associated injuries, and the complications. This table shows the results that we got. As you can see, the red circles point out the statistically significant differences. So DASH, PRWE, the pain at rest and pain with exertion, all these were higher in the occupational group. The only exception was regarding the range of motion, the extension, where the occupational group had a little bit less extension, 63 versus 67. Interestingly, type of fractures, no difference in associated injuries and also in the complications. We can conclude that the treatment seemed to be effective in both groups, but patients injured in an occupational setting had a much higher disability score, DASH, PRWE, pain at rest, and with exertion. Range of motion seems to be quite similar in both groups. In this case, only the extension was significantly different. Obviously, this study has limitations, a small sample of patients, his retrospective nature, and we also need to evaluate other variables as a long-term follow-up and the hand dominance of each patient. Thank you for your attention.
Thank you very much. These results seems to be in line with our experience, but could these difficulties change your follow therapeutical approach?
Well, I think to change the treatment would be quite difficult because the objective measurements seem to be quite similar. So, and the subjective ones, I don't think we can trace any different kind of treatment.
Thank you for your presentation. Finally, we go for a dorsally stabilized fracture by Dr. Liu from Malaysia.
Good morning. I'm Liu from University Putra, Malaysia. I'm here to share with you my case series of early outcome of AO type C3 and C2 distal radius fracture treated with single broad dorsal plate fixation. I have no financial disclosure. Recent studies had showed that there's increased use of dorsal plates, especially fragment-specific plates. Our main aim here is to evaluate the early outcome at 1 year, both using X-rays and functional scores of this broad dorsal locking plate in AOs type C2 and C3 type of fractures. This is the plates that we are using. Is a broad dorsal plate engaging the radial column and intermediate column dorsally. We have 7 patients with distal radius fracture type C2, C3 with CT showed dorsal instability, and surgery was done by a single senior hand surgeon. Pre and post-operative wrist X-rays were evaluated, and for the clinical assessment, we were using range of movement of the wrist, grip strength, quick dash score, patient-rated wrist and hand evaluation, modified Mayo wrist score. All were done at 12 months post-op. We have 7 patients, all male, mean age 27 years old, 3 with type C2, 4 with type C3. Mean follow-up period was 28 months. 3 patients had initially wrist X-fix for dorsal subluxation, and 1 of them had an open fracture grade 1. 2 patients required iliac bone grafting. This is one of our patients where he presented to us, referred to us on a wrist external fixator for dorsal couple distal and radius subluxation. And CT scan showed there is a comminuted dorsal rim of the distal radius, type C3, with metaphyseal comminution as well. And we plated it using this broad dorsal plate for the both column. For the X-rays wise, we were able to correct the alignment to the acceptable range. For the movement at 1 year, they were good, and the grip strength was 89.6% of the unaffected hand, correct to the 10% rule. All the scores were good, and average return to pre-injury work time was about 4.5 months, and at 1 year follow-up, there was no loss of reduction. And therefore, we can conclude that this single broad dorsal plating is useful in treating type C2 and C3 distal fracture with dorsal instability. And in our limited case series, we found no complications so far. With that, thank you for your attention.
Thank you. Yes. Going for dorsal plate osteosynthesis, what do you do for the extensor tendons? Do you have any idea how to cover them?
We close the extensor retinaculum using a step cut, and then we close the plate. For the extensor tendon, the EPL we leave above the extensor retinaculum. For the tendon-wise, we don't find any problems.
Do you remove the plate?
Sorry?
Do you remove the plate later on?
Up to now, all patients, we haven't removed it. We haven't got any indication to remove it.
Thank you. We have now
Thank you.
the next session, the next presentation. Should I stay or should I go? The question of removing the plate or not. Dr. Krasnitsky from Germany.
Yeah, dear faculty, dear ladies and gentlemen, we've heard a lot about the plating being the standard solution for the radial fractures, and as we all know, rightfully, it is the standard operative procedure, but it lacks a standard removal protocol. So why is that? We have guidelines, national guidelines in Germany, which have at this point 9.3, which relates to the hardware removal, and says generally that the indication must be provided on a case-to-case basis, based on the patient's age, activity level, complaints, and so on. So there's no particular formulation for that. Recently, Yamamoto et al. Had a systematic review of plates being removed after distal radius fracture, and what they found out was what we all deemed as being true. It's not routinely performed. With a low incidence of 6%, frequently, the frequency worldwide increasing, but yet very, very different, depending more on the social system and the healthcare system and the refunding of this procedure than the medical indication. Knowing that a recent other study from a group in Germany, in Mannheim, told us that patients that have the implants staying significantly longer in the body face significantly more complications. So is there a way to see if the removal itself is a safe procedure or not? If we regard the complication and see these x-rays, then we cannot tell whether the procedure itself is a safe procedure if the complications that we measure are related to something totally different. So we questioned ourselves, is there a difference in the complication rate after implant removal for medical indications or non-medical indications? So we regarded in a retrospective study our own distal radius fractures from September 03 to February 18 and collected age and gender, the classification according to the AO, the time lag from trauma to plating and from plating to removal, and had two groups, the indication group for hardware removal and the complications following the removal. So the medical indication are briefly the mechanical problems related to the hardware, the post-traumatic CTS, tendon rupture or tenosynovitis, the impairment of the function and the pain of traceable source. The non-medical indication were defined as the patient's wish or the foreign body sensation of the patient, a routinely performed HR, and the pain without a traceable source. So what we found out is a total of 66 patients out of 1,500 performed procedures, which makes a rate of 4.5% removals, which corresponds pretty much to Yamamoto's numbers, with the indication being equally distributed between the two groups. And I want to just highlight the complications, which is the most interesting one and the one that we rose a question for, which is significant. So I can conclude the complication rate following implant removal was a total 5%, with a significant difference between the two groups and no complications in the non-medical group. The implants that were removed 22 months and later were associated with much higher complication rates, so we can conclude that routine removal of the plate is a safe procedure, and we can now put it that way that the removal after the volar plating could be a uniform and internationally consented procedure and should be routinely canonically recommended, at least to the patient. Thank you very much.
Thank you for your presentation. I agree totally with you, and especially less aged patients are regarded to be removed the plates, and that's very important. That's what I think as well. Thank you for respecting the time, all presenters, and we wish a very nice day for everybody.